Bismillah Rahman Rahim. Welcome to my lecture number 16. Dear students, in this lecture we will discuss about the drug therapy of migraine. So as we know that migraine, this is one of the clinical conditions, and this is very common, especially in our society, and most of the people, they are suffering from a migraine-like condition. So today we will talk about the drug therapy of migraines. So first of all, we will define migraine. So migraine is a mysterious disorder characterized by pulsating headache restricted to one side, which comes in attack lasting 4 to 48 hours and is often associated with nausea, vomiting, sensitivity to sound and light, flashes of light, and vertigos. In simple words, migraine is the clinical disorder which is characterized by the pulsating headache, and that headache is restricted especially to one side. And actually this attack comes after lasting 4 to 8 hours, which is often associated with nausea, vomiting, and sensitivity, but it is not necessary. Simplified, the diagnostic criteria for migraine: repeated attack of headache lasting to 4 to 72 hours and a patient with a normal physical examination, no other reasonable cause for the headaches. At least two of the following features which are seen here: unilateral pains on one side of the head, and that is throbbing pains, a repetitive type of pains sensations which is felt by the patients, and aggravation by moment. It means this pain is increased with moment and moderate or severe intensity. Look at here, plus at least one of the following features. There may be nausea and vomiting, photophobia, and you can say phonophobia. The person have a super class, you can say, perception toward light, and you can say these are the clinical features which are reported by the different literatures. You know, there are two types of migraine. The first one is migraine with classical migraine. So in classical migraine, there will be headache preceded by visuals or other neurological symptoms. Migraine without aura, there is common migraine. So there are two types of migraine. One is classical and the second one is common. Look at here. There are 4 stages of migraine. So the first stage is called prodromals, or you can say prodrome. The second one is called aura, and the third one is headache, and the fourth one is postdrome. So these are the different stages. You can see the picture, the condition of the patient. So all these patients, they are suffering from migraine. The first stage, which I am going to explain, that is prodrome. So in prodrome, there is a vago premonitory symptom that begin from 12 to 36 hours before the aura and headache. So these are the symptoms, the classical symptoms, the clinical feature of prodrome. So the first one is the patients will be suffering from, you may say, these are the classical feature of this disease of migraine. So the symptoms which are reported, that may be in the form of yawnings. Yawning is the process. It is mostly involuntary process of especially opening of the mouth and breathing deeply and filling the lungs with air. So simple, this is involuntary process of opening of the mouth. Sometime when the person become bored, so after that, in simple words, you can say involuntary process by opening mouth and breathing deeply to filling the lungs with the air. The second one is excitation. This is another classical sign symptom of prodrome. The third one is depression, and the fourth one is lethargy. Lethargy means sluggishness, slow craving or distaste for various foods. The normal duration for prodrome is 15 to 20 minutes. This is the normal durations. It's not for a longer period of time, but how much? The second one is aura. This is the second stage. Aura means it is a warning or signal before the onset of headaches. Before the attack of headache, this is just a signals which is given to the warning or signals to the person before the onset of headache. These are the various symptoms which are reported. So the first one is flashing of lights, zigzag lines, randoms, and difficulty in focusing. The person become unable to focus on a single things. So in simple, the normal duration of aura is 15 to 30 minutes. This is a very short duration. Now come to our headaches. Headache is generally unilateral on one side, and it is associated with symptoms like anorexia, loss of appetite, nausea, vomiting, photophobia and phonophobia, and tinnitus, ringing in the ear. The normal duration of headache is 4 to 72 hours. So after taking certain medications, that the condition recovers. The fourth one stage is post-traumas. So this is the fourth one stage of the migraine. Following headache, patient complaints of these are the various symptoms, signs and symptoms which are reported. So the persons may have fatigue, exhaustions, depression, severe exhaustion, and some patients feel unusually fresh. While the duration for post-trauma is few hours up to 2 days. Now these are the various factors which are responsible for the migraines. These are the factors which can triggers actually the migraines, the aggravating factors. So the first one is food. Depend upon on your food, on your eating habits. There may be sleep disturbance, disturbed sleep patterns, and there may be some internal, you can say, hormonal change may be occur, visual stimuli, and the drugs, especially the drugs which are used for the different type of ailments. The physical exertion, this is another factor. Visual stimuli, the things which you can see with your naked eyes, auditory stimuli and olfactory stimuli, weather changes, hunger, frustration, and psychologically, all these factors can trigger the migraine. Now what are the clinical etiology causes of migraine? So it's simple, these are very simple. So the first one is especially in case of migraine, there increase the excitability of central nervous system, while there may be the meningeal blood vessel dilatation can be occurs, especially meninges, which is the traplet layer of the brain, pyometer, durameter, arachnoid meters. So actually the blood vessels should become dilated. While in third case, the third you can say the clinical etiology of migraine is activation of perivascular sensory trigeminal nerves, because the migraine, this is also directly related with your nerves. So one is cranial nerve and the second one is spinal nerve. So this is directly related with your cranial nerve, and cranial nerve, the most important nerve, that is trigeminal nerve. So after the activation of perivascular sensory trigeminal nerve, pain impulses may be occur. This is another cause. Vasoactive neuropeptides contain substances like P and calcitonin, gene-related peptide, CGRP, and kinins A. Combination of increased pain sensitivity, tissue and blood vessel swellings and inflammation. So these are the common causes which are reported by different literatures. Now come toward the pathophysiology of the migraine. Pathophysiology means how this disease is caused, how this disease is produced, through which mechanism this disease is produced. So there are two changes which is seen here. Look at the screen. So, and pathophysiology, the first one is vascular theory. So in vascular theory they have explained that they have intracranial and extracranial blood vessel or vasodilatation can occur, so which is the main cause of, you can say, which may produce headaches when the intracranial or extra cranial blood vessel become dilated, especially the pressures which is produced inside your craniums, especially the blood vessel, when the blood vessels of the cranium, so it become dilated. So when the blood vessels become dilated, so there may be chances of headache, and intracerebral blood vessel constriction occur, especially in the aura. The second theory which is related to serotonin theory. So in serotonin theory explained that there may be chance of decreased serotonin level linked to migraine. So especially in migraine, when the serotonin level, so it become decreased, so it means there may be chances of migraines. So the second mechanism of, as we know that there are some particular and specific serotonin receptors which are found in the blood vessels of the brain, so vasodilatation can occur. So these are the two theories which have explained the basic pathophysiology of migraine, how migraine can occurs. Now this is the clinical classifications of the migraine. One is mild, moderate, severe. In mild cases, this is less than one attack a month. So one attack is possible in a month, lasting up to 8 hours, throbbing pains but tolerable headaches. It means this is not for a longer period of time. This is mild. This is very minor case. The second case is moderate. In moderate cases, one or more attacks per month, while almost 6 to 24 hours, but there is intense throbbing headache with nausea and vomiting can be occurred. This is moderate case. It come in the middle category, while the third one case, that is severe case, in which the almost 2 to 3 attacks they are possible or more every month, so they are possible, and its time period is almost 12 to 48 hours, but there is intense throbbing, headache and nausea and vomiting, vertigo, GIT, instability, gastrointestinal tract instability, fatigue and photophobia. Drug therapy of migraine, this is very simple. For example, if the condition of the patient is severe, so this is the simple drug therapy. So especially in mild cases, let's suppose in drug therapy of migraine, in case of mild cases, simple analgesics are used instead, non-steroidal anti-inflammatory drugs or their combination, or you can use or not. If there is vomiting, then antiemetic can be used, like chlorpheniramine, maleate and many more agents like metoclopramide, so they are used. And moderate cases, instead non-steroidal anti-inflammatory drugs, they are used in a combination with ergot alkaloids and like somatriptans plus antiemetic if vomitings is occurs. In severe cases, ergot alkaloids, especially somatriptans and rizatriptans, plus antiemetic agent, and plus prophylaxis is the treatment before the entry of microorganisms. As we are using the propranolols, other beta blockers, which are also used in the treatment of hypertension. Amitriptylines, they are used, amitriptyline, so these are also it come under the category of antidepressants. So as long as along with the migraine there is chance of depression, so amitriptyline is used, 5-hydroxytryptamine is antidepressant, and other tricyclic antidepressant like fluoxetine, duloxetine, flunarizines and other calcium channel blockers, verapamils, valproate and topiramate, they are used, and simple, these are the drugs, methyser, guides and cyproheptadine, so these are the different agents which are used in the management of migraine. Now come toward the clinicals, the treatment protocol for the mild migraine. They are already given here. Especially simple analgesic is used in case of mild migraine. Simple analgesic they are used. that may be in the form of paracetamol at the dose of 0.5 to 1 gram. 0.52, look at here, simple analgesics paracetamols, 0.5 to 1 grams, or aspirin 300 to 600 milligram repeated 4 to 6 hourly. NSAIDs can be used non-steroidal anti-inflammatory drug ibuprofens at the dose of 400 to 800 milligram 8 hourly. Naproxen sodium diclofenac 50 milligram 6 to 8 hourly, and mefenamic acids like Ponston, etc. It can be used. In case of let's suppose if the patient is vomiting, then antiemetics are used, like metoclopramide 10 milligram oral or IM. Domperidone can be used, like Motilium 10 to 20 milligram. It can be given, and Nevidoxine, etc., meclizines in a combination with paracetamol. Codeine, diazepam, diapine, hydramines, or another antihistaminic caffeine can be used. In case of mild migraines, let's suppose a patient with mild migraine, so we can use stronger NSAID non-steroidal anti-inflammatory drugs, or the other combination like ergot preparation, which I have already explained, and the tables, or sumatriptans, they are used. And severe migraine, ergot alkaloid like sumatriptans are used. I think the drug which is available in a market by trade name, that is, I think, sumatriptan, zolmitriptans, that is Ziclopel. So Ziclopel capsule, they are available, so you can use it. Ergotamine. So ergotamine is the most effective ergot alkaloid for the migraine. The best choice, the most effective ergot alkaloid, you can say a choice for the migraine given only in the attack. Oral or sublingual route is preferred. 1 milligram is given at half-hour's interval, 10 relief of times, or the total of 6 milligram is given act by constricting the dilated the cranial vessel, because especially in migraine the cranial vessel, especially the cranial nerves, trigeminal nerves, had become dilated. So after administration of ergotamine, so they act by constricting the dilated the cranial vessels, or by specific constriction of the carotid AV shunt channels, while it reduces the neurogenic inflammation and leakage of plasma in durameters. Why are triptans superiors? Why triptan they are superior over other drugs? Because we know that ergotamine has low bioavailability, that is less than 1%. So definitely if the drug is low bioavailability, so then its effects will be low. Better after rectal or sublingual administrations. Many adverse effects which are reported, so it may produce nausea, muscle cramps, coronary spasm, etc., and CIA and sepsis, IHD, and as well as the you can say pregnancy, etc. Background and rebound headache may be occurred. Another group that is called Selective 5-hydroxytryptamines, 1V1T agonist, sumatriptan, Selective 5HT, 1V/1D receptor agonist. Actually, sumatriptan, this is also a drug which is in the treatment of migraine. It can be administered at the onset of attack of migraines, and constriction of the dilated cranial extracerebral blood vessel, especially the arteriovenous shunt and carotid artery. So reduce 5-hydroxytryptamine and inflammatory neuropeptide release around the affected vessel, reduce the extravasation of the plasma proteins across the dural vessels. As we know, there are 3 layers, especially that is called meningeal layers: pyometer, durameter, and carotid meters. So it means that if you can say in migraine, these the different areas of the brain, they are affected. So in order to reduce the inflammatory mediator release, CGRP, NK, and SP, suppression of impulses transmission in the trigeminal-vascular pathway. 3 dosage form: oral, nasals, and parenteral costliers. Advantages over ergotamine. So actually the ergotamine, it is better tolerated than ergotamines. Faster relief than ergotamine, 25 hours, lesser rebound headache and background headache, also able to take care of other related problems, for example nausea, photophobia, etc. These are the various side effects which are reported: tightness in the head and chest, feeling of heat, paresthesia, and limbs may be occurs, which are reported. Dizziness may be occur, weakness, and rare cases bradycardia may be occur, decreased heart rate, coronary vasospasm, MI, myocardial infarctions, seizure and hypersensitivity reaction may be occurs. Indication for prophylactic therapy: 2 or higher frequency of attacks per month, migraine attack not responding to acute drug treatment, frequent, very long or uncomfortable RES. Prophylaxis start with low doses with therapeutic effect, each to be taken daily and take at least 2 to 6 weeks to act. Course is almost 5 to 6 months and gradually tapers, increase or decrease or discontinues. Beta blockers are also used. So propranolol is the commonly used drug, reduce the frequency as well as the severity of attack. So a beta blocker is used. So as we know that the most dominant receptor which is present in heart, that is beta 1 receptor. So the effect seen in 4 weeks, the dose is start with 40 milligram BD, increase up to 160 milligram BD. Tricyclic antidepressants, amitriptyline, can be used 25 to 50 milligram at the bedtime. Calcium channel blocker, verapamil and flunarizines, you can say weak calcium channel blocker, that can also inhibit the sodium channels. Anticonvulsants can be used like valproic acid at the dose of 400 to 1200 milligram per day. Gabapentin can be used 300 to 1200 milligram per day. And 5-hydroxytryptamine 5-HT antagonists can be used like methyser, and you can say the cyproheptadine, they are also available. So this is prophylaxis, the treatment before the entry. These are the drugs. So the first one is beta blockers. Beta blocker are propranolols and nadolols. So propranolol is available at the dose of 40 to 320 milligram. These are the adverse effects which are reported by the propranolols. If overdosing occur, bronchospasm may be occur, bradycardia, hypertension, fatigue, depressions. Nadolols. So nadolols at the dose of 40 to 240 milligrams, the same adverse effect they are reported. Tricyclic antidepressants, so amitriptyline is available at the dose of 10 to 175 milligram. Sedation may be occur and xerostomia, weight gain, cardiac arrhythmia, urinary retention and constipations and tremor may be occur. Nortriptyline, they are also available at dose of 10 to 125 milligram. These are also the adverse effects which are reported here. The anticonvulsant agent divalproic sodiums like epival, which is available at the dose of 250 milligram to 1500 mg. So it may cause teratogenic developmental abnormality, nausea, hear loss may be occur, hepatotoxicity, weight gain, tremor and fatigue. These are the adverse effects. Calcium channel blockers can be also used like verapamil, which is available at the dose of 240 to 480 milligram, depend upon on the condition of the patient. So it may cause hypotension, edema and constipations. A successful prophylaxis, a decrease in the frequency of migraine attack per month by at least 50% within 3 months. Thank you so much for watching my lecture. Inshallah, in my 17 lectures, so I will tell you inshallah about the different treatment protocols, especially regarding what are the basic nursing care which is provided by the nurse during hospital. So thank you so much for watching my presentation.